Welcome to VLU Grand Rounds. It is a pleasure to introduce myself as the host, Lowell Kabnick, and our guest host, Sarah Onita. We have a wonderful group of physicians today, starting out with Stefano Ricci, who has published this book, if you can see it, on phlebectomy. It's worthwhile, and we're going to be talking about phlebectomy, when and why. And we have discussants, Professor Boskirk and Dr. Kirsten Simmons. With that being said, I'm going to turn it over to Stefano, and would you begin?
Okay, I will show some slides about the subject I was asked to speak about. So I was invited to speak about phlebectomy, when and why. However, I will say few words about what phlebectomy is, in my opinion. Phlebectomy has a sense when done as an ambulatory procedure. Its definition, classical Muller's technique, varicose vein avulsion under local anesthesia through multiple stab skin incision, 0.5 to 3 millimeters, not requiring sutures, followed by hemostatic compression and immediate ambulation. You all know what it looks like, a simple procedure with few instruments in an office setting. Why to do phlebectomy? Naturally, for elimination of varicosities, because it is easy, fast to be performed, effective because all varicosities are eliminated, repeatable if you have a recurrence or you were wrong in deciding the type of phlebectomy, and safe. As you can see, the limited bleeding, it's safe even in dangerous sites, like in this case, foot dorsum, small incisions. But the most interesting speculation is when to do a phlebectomy. It can be associated with great saphenous vein ablation treatments, either as a concomitant or staged procedure, or at the opposite, managed as an isolated procedure when a sparing Saphenous tactic is performed. When concomitant to ablation, it has the advantage of fully completing the treatment in a single session. However, it requires a longer operative time.
Stefano,
yes.
Stefano, sorry, but we can't see the presentation.
That is
It's interesting. There's some that can see, there's some that can't.
Can you see that?
I am perfectly seeing your presentation, and it is advancing. Sarah, are you having any issue?
I'm afraid I cannot, actually. I think I'm having the same issue as some of the other participants. I've got the phlebectomy when and why sort of flyer, but I can't see the slides advancing as of such.
Oh, I am. Interesting. All
I
right.
first couldn't, but now I found it.
What can I do?
What I would suggest is just to continue, and
Yes.
we will listen carefully,
Yes.
and then we will start to ask questions. Thank you.
Yes, probably the pictures are not so important.
Dear Lowell, this is Lourdes Reina. Please look for the shared screen of speaker, not Lowell's one.
I see.
You can select
Yep.
the Lowell's
can do it.
screen
I
or
got it.
speaker.
Right.
speaker.
Yeah.
That is the solution. Okay, bye.
Thank you.
Thank you.
So shall I continue?
Can
you try
yes.
it now?
Probably only the speech is enough, I think.
I would think so.
So
Now,
Yes, it's advancing.
now everybody's seeing it?
Yes.
I haven't done anything yet, but go ahead.
Okay, don't do anything, Lowell.
can you see something now?
Yes.
So I still can't see them, but I think in the interest of time, it may be better to sort of continue with the presentation
Yes,
verbally?
I think so. I think so. So I was talking about that when to do a phlebectomy. So it can be associated with great saphenous vein ablation treatments, either a concomitant or staged procedure, or at the opposite, managed an isolated procedure when a sparing saphenous tactis is preferred. When concomitant to ablation, it has the advantage of fully completing the treatment in a single session. However, it requires a longer operative time and may lead to overtreatment. As a stage tactic, even if it involves a shorter procedure, it often requires further treatment, in many cases not providing immediate varicose abolition. Although opinions differ about the preferred solution, as shown in the reference below, in particular Oneida 2012 on phlebology, it appears that results are similar in medium terms, the choice depending on the operator's skill, anatomy, patient's preference, and organization. But more interesting is, in my opinion, the isolated phlebectomy, when gray saphenous vein conservation is the goal, like in Shiva or Asval techniques. Reflux in the great saphenous vein may disappear after tributaries avulsion when the re-entry perforator is centered on the saphenous stem. This anatomical condition may be revealed by the reflux elimination test, according to Zamboni's suggestion. What is RET, reflux elimination test? A digital occlusion on the tributary stops the great saphenous vein reflux when the re-entry perforator belongs to the same tributary, like in most of the cases. In the A scheme, the most frequent varicose condition is shown. About 70% of cases, the reflux goes in a tributary that have his own re-entry perforation. This is a red positive case, and in this case, the phlebectomy has a good result, making the reflux disappear. In the next scheme, the less frequent condition, when one re-entry perforator is placed also on the saphenous stem. This is a red negative situation. Occlusion on the tributary does not stop the reflux. The phlebectomy will not stop the reflux, although reducing volume. In these cases, in any case, there is an amelioration of the symptoms. Isolated positive aspects, so are varices elimination, saphenous conservation, limited costs, immediate ambulation, patients' enthusiastic approval for saphenous conservation, and easy repeatable. This study by Beeman shows interesting result with 75% of reflux abolition by phlebectomy alone at 1 year, over 100 patients. The author suggested a scoring chart for success prediction, considering the RET together with other parameters. If we take an example, a C2 case with a single segment involved, RET positive with a 6 millimeter diameter, we can calculate 3 plus 3 plus 2 plus 5 points, a total of 13, with an 89% of success rate. Finally, I would like to recall the fact that gray saphenous vein reflux with competence of saphenofemoral junction is very frequent, and it may be found in 50% of the cases of saphenous reflux. In this case, phlebectomy alone may be sufficient. Thank you for the interest.
Thank you,
Thank you.
Stefano. It's brilliant as usual. Of course, there are lots of questions that are coming, but I'm going to go directly to Professor Boskert to comment and ask questions.
It was really very nice presentation. I'm always asking to myself, honestly, why we are very keen to keep long saphenous vein intact. Do you think it is very important? If we say it is important, why? For future use in coronary artery bypass grafting, for future use for FEMPOP bypass procedure. I'm a cardiovascular surgeon. I am doing cardiac surgery. I know how important is the saphenous vein. I know how important is for bypass procedures. But I have been doing for 21 years now endovenous ablation. Maybe 3 or 4 patients needed after sometimes saphenous vein itself. So, Professor Ricci, I mean, I'm 100% respectful whatever we do, whatever you do. But, instead, why we are not just blocking, closing the long saphenous vein? What do you think about it? What's your opinion about that?
I think that saphenous vein is an important vein. We need the saphenous vein for superficial circulation, apart from the bypass need that is, however, very important. But we must not do a revolution of the circulation. We need a big vessel that drains the superficial venous circulation, and preserving the great saphenous vein. Why should we take off a vein that may be left inside? We can have a more simple operation, less costs, and why should we do something that is not needed by the circulation? Especially in C2 cases, we have usually 5 millimeters, 4 millimeters, even 6 millimeters diameters of great saphenous vein, which is a nearly normal vein. So the tendency of eliminating such a vein is probably a hyper intervention, over operation. So this is a choice, a philosophical choice. I think that to take off a saphenous vein is easier. You must not do too much work about research and too much work about speculation. You just do it.
I'm going to interrupt you here because I think we're a little bit off task. To me, it's about phlebectomy, when, where, and why, and what are your alternatives. So I'm going to go to Kirsten Simmons and please comment.
I strongly agree with you, Dr. Ricci, that doing purely phlebectomies and leaving the saphenous vein intact if there's no problem is certainly a very good form of treatment. And I mean, what I try to do in my practice is that we try to individualize every patient's treatment in saying, the one patient may need only the phlebectomy, the other one may need the saphenous vein influence as well. And I think even if it's just a small vein, which is incompetent, which is also bothering, you can take it out so easy with local anesthesia. And personally, I find, what is the other alternative we have, which is the foam sclerotherapy. And I must say, I personally am far more in favor of the actual physical phlebectomy that we as surgeons do. Because in Germany or in Switzerland, where I'm now, it's a bit limited because the angiologists can't do it. So they like to promote only the foam sclerotherapy, which I certainly do not share that view. because the patients often frequently have pain in the treated vein for a long time, whereas with the phlebectomy, yes, you have a hematoma, but then it's over and done with. And I find it more satisfying also for the patient. I don't know how you see that, but so yes, I'm very much in favor of doing also just phlebectomies.
So it seems like we have a consensus here of saphenous-sparing, phlebectomy being fun, but really where I want to go to, and I'm going to let Sarah get in here in a moment, is when do you do phlebectomy? When do you do sclerotherapy? Dr. Bishara has said, does the technique work if it's 6 millimeters or more, etc.? So these are questions to you, Professor Ricci. When do you do sclerotherapy over phlebectomy? Some people combine foam sclerotherapy with phlebectomy when they're doing phlebectomy. What's your opinion?
I think that it depends on the skill of every operator, but I think that phlebectomy is very good for for larger varices, and a finissage is perfect by the foam sclerotherapy. So this is what I would do, and I was doing usually.
Sarah?
Just a couple of comments. So I think this is sort of a really good discussion, and I can see both sides of the argument. I work in a sort of National Health Service type hospital, and the patients that we see, even with C2 disease, absolutely are extremely symptomatic. Often we see patients that are C3 plus or C4 plus disease, actually. And we, as part of routine practice, in the context of having important tributary incompetence and refluxing saphenous vein, we would normally ablate and avulse at the same time, or do the ablation and foam sclerotherapy at the same time. Clearly, that is also very much patient dependent. So as Kirsten was saying, personalization of treatment is really important. So you need to see what the patient's symptoms are, what they're presenting with, hemodynamically, anatomically, what is the best surgical option, and what do they want? Do they want to have it under local? Do they want to have it under general? Do they want to have the phlebectomies? Do they want the scars? Would they rather have foam sclerotherapy? Are they extremely frail? Do they need a very quick in and out procedure for an ulcer with subulcer foam sclerotherapy, for example? So there are lots of different variables that we need to look at. But for a standard patient with C2 disease, we've elected to go down the path of doing concomitant phlebectomy, really based on the avulse trial that one of my colleagues, Tristan Lane, did many years ago, looking at delayed phlebectomies versus concomitant phlebectomies. And actually, we found that in our group of patients, over 30% of those who had only the saphenous trunk treated then needed further intervention for the tributaries. Whereas actually in the concomitant phlebectomy group, only 2% needed additional treatment. So based on that, in the context of the NHS and giving sort of the best possible treatments in a one-stop fashion, we normally do them under local anaesthetic with concomitant phlebectomy. But it really depends on the patient, and that isn't sort of a dogma. That is the unit policy, but clearly changes based on patient wishes and what is appropriate for those patients. In some cases, it is foam sclerotherapy. I tend to agree with Professor Ricci. I tend to go with the very large, big varicosities. I tend to do phlebectomies if it's someone who's quite elderly, who, you know, isn't worried about sort of the risk of hyperpigmentation or that, and there's quite extensive smaller veins, or there's an ulcer present. I tend to go for foam sclerotherapy, but again, it's on a case-by-case basis.
So this argument continues on whether you should be doing one and done or you should be staging. Dr. Omar Esponda raised that question about staging. I believe in phlebectomy. We've done phlebectomy under local anesthesia ad infinitum, along with truncal ablation. And there have been some papers to support that if you do it together, the quality of life is more improved. But then again, perhaps you're doing unnecessary work. And there is that belief, that strong belief that you are overdoing when you're taking everything out that you can see. Because as we know, when you do a truncal ablation, that there is going to be some decrease in those varicose veins. And I see Massimino Capelli, who is one of our stars for Chiva, and he probably would agree that we should probably not necessarily take out the saphenous vein. But that being said, in the US, that is standard of care. I believe it is also, if it's refluxing, I believe that's the standard in the United Kingdom.
Yeah, that's correct.
There's not the asphalt of the Chiva, but that remains to be seen. Maybe that will percolate a little bit here. I know that there are people that are watching from Spain. Lourdes would probably tell us that a lot of that's being done in Spain, the Chiva technique, and certainly in Italy. But I think what I'm looking at is we have two options. We have phlebectomy and we have sclerotherapy. In the US, because of the time, a lot of people are doing sclerotherapy. And they're doing sclerotherapy under the proviso that that patient's going to come back to their office, and in a significant amount of time, they're going to have to be drained. They don't figure about that time, but the question is cost effective.
I was about to ask, does the patient pay every time?
So the cost effectiveness with phlebectomy versus sclerotherapy, what does the panel think?
If I may start, in Germany and in Switzerland, the phlebectomy is paid by the medical aid, the foam stereotherapy not. So here you have the first issue arising. And depending on how you then handle it, if you have to recharge the patient every time he comes, even to have them have it drained, if there's a retention of hematoma, etc., in the sclerotherapized vein, I'm not so sure that they will inevitably be so particularly happy. So for that reason, just also bearing in mind what the cost is, I tend to prefer going with the phlebectomy also, and being honest with the patient, and telling them. So I don't know what the cost.
Any other comments?
In other countries.
I mean, my comment is that treatment of venous disease as a whole is cost effective, whether you do it by ablation or foam or phlebectomy, because of the improvements in quality of life. Foam, my understanding, is quite cheap compared to the fact of then needing sort of a theatre, instruments, this, that, the other. I mean, we do office space, but it's sort of in a clean type theatre room as opposed to truly in an office. We could do sclerotherapy in an office. We wouldn't be able to do phlebectomies in an office. It would need to be in sort of a specialised room. So the additional sort of man-woman power and sort of kit and everything else that would be required, I suspect makes phlebectomy more expensive on the NHS than foam sclerotherapy is. And also in terms of time, phlebectomies take longer than an injection of foam sclerotherapy often. So I think from a purely cost perspective, sclerotherapy would likely be cheaper. Now, depending on the individual patients and this, that, and the other, you need to then assess the quality of life, the results of those patients, and on further follow-up if they have recurrence, to see how many further sessions you need to do to then calculate the cost effectiveness properly. But I think as a one-stop thing, foam is probably cheaper. Does that mean it's better? I think it depends on the patient.
But does the NHS cover foam?
Yes, for symptomatic.
That's okay.
Symptomatic C2 disease.
That's then, of course, the difference.
Exactly. Anyone who's asymptomatic is not treated unless they've got skin changes. But symptomatic C2 disease, yes.
Okay.
So we often see patients that have more than just a little in terms of varicose veins. And they can be on a thigh, they can be on a calf, they can be on both of them. Stefano, as our skipper here, if you see somebody with an abundance of varicose veins, would you do it all at one time, spend the 2 to 3 hours, or would you stage it? And if you stage it, what do you expect you'll see?
In my experience, in very heavy cases, I divide the operation in 2 sessions. In particular, after the first session and after the bandage of the leg, you will have a very great reduction of the venous network on the second session. So what I like to do is to divide the operation in two sessions, staged once week, one after the other, with a quite big, heavy compression in the meanwhile. So I would not do it all in the same time, but I would divide the operation in two sessions.
Sarah, do you disagree?
I don't. I think in my practice, if someone comes in with absolutely huge, great black varicose veins, I mean, we do them under local or general, and those patients, especially if they're bilateral, I might counsel and say, look, might be better under general action and get everything done. Some patients absolutely don't want to do that, and they really want to have it all done under local anesthetic. And, you can get quite a bit of vein out with phlebectomy under local. So in those cases, I try and get as much as I can out on a single session. And if they need any additional sessions, then they do. And again, often, they're plagued by symptoms. They're less worried about the fact that they've got big veins. They're more worried about the fact of, having leg heaviness and pain and aching. So if you treat the truncal reflux and you reduce the burden of the varicose veins or the incompetent tributaries in those symptomatic C2 patients, sometimes that, can be enough. And then they come back and they go, actually, I've got a few veins left, but they don't bother me at all. Thanks very much. I'm very happy with what I've had. Some instead come back and say, no, I still have symptoms, and then they need another session. So it really depends on the patient. So I don't disagree.
Yes,
So we have 4 minutes left. I'm going to hijack this for a moment and ask parting shots from Professor Boskirk. We'll end with you, Stefano. Parting shots.
Sorry,
Kirsten,
what-
comment, questions?
No, not really. I'm fine.
Well, thank you for joining us, Kirsten.
Please.
Any questions? No really questions. Thank you very much.
It's kind of interesting. We didn't talk about complications of phlebectomy.
I was expecting that actually, yes.
And we have 2 minutes left. We do know that there are complications.
Can I show you a slide about complications if you want?
The nerve issue in unexperienced hands is certainly an issue, as well as the matting, which also can happen.
Especially the skin nerves that you
Yes.
see often. Yes.
Yes.
There we
I mean,
go.
today also I had something which I thought, oops, what was that? But the patient was fine afterwards. So I don't know what it was, but I was a bit worried.
So,
Do you see the slide?
Stefano,
Yeah.
yes.
So this is over 1,000 patients. So you see the complications. The most important complication is matting. And in red there, I signed the most important complication in my view. So permanent pigmentation, matting, and visible scars. However, very low frequency.
Interesting. Yeah.
The phlebectomy is a tool. It is made by your hands, and I think I joined. I have a quite good technique, and I think it is possible to have very few problems.
I have a question for you. Sarah, do you use steri strips or sutures? And Kirsten, the same, and Kirsten, same question.
We actually use nothing because the incisions are so small. We simply put a tight bandage, well, sterile, what's it, plaster something over it, but no steri strips, nothing. I used to use steri strips, and I wasn't at first convinced. So only if it's a little bit of a bigger incision, then I would use a steri strip. Otherwise, not. But certainly no.
They usually cause blisters. I'm going to have to stop this. We have 1 minute of the hour, and I wanted to thank everybody here. Thank you very much for participating. Next week, we're going to be talking about aesthetic sclerotherapy, indications from procedures. Lena Vargas from the US will be our speaker, and Lourdes Gutierrez will be our discussant, as well as Claudine Desnos Amos. So we look forward to that, and please join us next week, Wednesday at 12. Thank you very much, and have a good day.
Thank you very much,
Thank you.
all.
Thank you.
Bye-bye, everyone. Bye-bye.
Bye-bye.
Thank you.
Bye bye.
Sarah, can you stay on for a moment?
Yeah, sure.